And now ready for a very exciting session today, the microbiome, a primer for health professionals in rheumatology. I can't remember we have had this topic at EULAR Healthcare Professional previously. My name is Bente Abel Esbensen. I'm a nurse and professor in self-management. I'm from Denmark. And it's my pleasure to chair this session together with Khadija. Yeah.
Good morning, everyone. Thanks for being here today, this early. We appreciate that. It is my pleasure, together with Professor Bente, to chair this session about the microbiome for healthcare professionals. And we have to say that over the past decade, the microbiome has evolved and advanced from a fascinating field of basic science to a field with potentially important implications also for clinical practice. We have today evidence on the complex interactions between the microbiome, the immune system, inflammation, and also environmental factors that shape disease and health. We are reconsidering fundamental questions about disease development, patient response to treatment, and also how to integrate diet, lifestyle, and physical exercise. The field is rapidly evolving and advancing, and we are fortunate to have three distinguished speakers with us this morning that will guide us through this topic. We will handle the Q&A after the session. We will have a part for discussion. So keep your questions and let's keep the session engaged at the end. And also, you will have a QR code on the screen for those who want to participate with different languages. The session will be, like through the app, will be, if you scan the QR code, you will have also other languages. Thanks for being here, and let's begin.
Thank you. And the first speaker, that is Borja Martinez-Telles. Welcome, Borja. Borja is a research fellow at the University of Almere and co-founder of MESUP, and he will give an exciting presentation. Thank you.
Thank you so much for the introduction. Also, I would like to thank the committee. It's my first time in the EULAR conference, so I'm really excited to be here and to participate to explain a little bit about the work that we have done in the past. And also, as we agreed, I would like to make a short introductions about what are the basics topics about the microbiome and the microbiota. So then we can build up with the three talks in directions that everybody will understand the meaning of more or less everything. These are my conflict of interest. I have a patent about one gut bacterium that can increase its muscle strength. And also, I am co-founder of a company. First, we would like to clarify two simple terms that normally people and the literature really make not super clear. The first of one is the differences between microbiome and microbiota. They are not the same. This is important to understand in the moment that we are analyzing the data and interpreting the results. Basically, microbiota refers to the microorganisms that are living on us or in us, and the microbiome are the genomes of these microorganisms together, the microorganisms. So it's the combination and it's also the genome that is there. And basically the microbiota, or almost every cell alive, categorized in these three domains of life. As you can see here in pink, we have bacteria, in purple, archaea, and eukaryotes. So these three domains are the main compositions of the microbiota itself. And we need to acknowledge that the most of the evidence that is coming so far is coming from the bacteria. So if you take a look through these three big bubbles, you see that the most of the evidence is coming from the pink part. So you can see that there is a lot of things that are not really known in terms of the microbiology within our gut or our skin. Also, this is kind of a really basic question but is important to understand. What are the differences between eukaryote cells and prokaryote cells? Eukaryotes are basically all the cells that we have in our body, all the cells that we really know. And the main features of these cells is that they are super enriched in mitochondria, which are the powerhouse of generating ATP. And also the DNA is in the nucleus. Basically, most of the assumptions that we know in biology are coming from eukaryote cells. Then if we see on the left, we see the prokaryotes. And prokaryotes basically are the bacteria and other microorganisms that we have in our body. And the main features of that is that they are super small, they are tiny, the nucleus are not, or the RNA, they are not super well compact, and they don't have mitochondria, for instance. And this is important to understand because there is some basic knowledge that has been taught to us in the schools. For instance, essential amino acids can't only be incorporated into the body through the diet. This is an assumption that more or less everybody has heard about that. But this is not longer true if we take a look to the prokaryote cells, because we have bacteria in our gut that can produce those essential amino acids. So this is the understanding of this, how this bacteria or this prokaryote cell works is reshaping also the basis of the biology that we know so far. For me, when I started to understand this, for me, I am kind of nerd about the space and how everything works. So I was really thinking about the composition of the Milky Way. I mean, how many stars we have there. Of course, there are some people that there is not boundaries in the Milky Way. We can discuss about that later. But if we establish kind of the limits of the Milky Way, and then we compare only with the amount of microorganisms that we have in our gut, we can see already the differences. So the Milky Way is kind of composed about 100 billion stars, and the microbiota is composed by 100 trillion of microorganisms. So it's way more. So we know better the composition of our Milky Way than we know better than the composition of our gut. So this is also already telling us how big is this small universe that we have in our intestines and how little we know about it. Those microorganisms are organized in taxes. These are like the domains of life, sorry. Here we see an example. This is the pyramid, because everybody, when is talking about a phylum, which is kind of a bigger family of where you can frame the microorganisms. And then also you have the species. So if we compare, for instance, a lion and a human, we are belonging to the same phylum, the same class, the same order. But then if we go to the species, we're completely different. A lion is not a human, right? So we know that also the biology works differently between animals and humans, and everything is not the same. So this is important to understand when, for instance, we are comparing to the most famous bacteria that we have in our gut, like Lactobacillus or Bifidobacterium. It can be the same comparison if we were comparing lions and humans. We are not the same, and these bacteria are not the same, although we try to really frame and to understanding all together, but this is kind of different because they have different functions between them. Also, it's important that when everything started about the microbiome, we have, or people, when they started to investigate it, they have discovered that the microbiome or the microbiota differs a lot across the body. Here we have an example that we see that the composition, this is at levels of the phylum, as you see in the right triangle, is in the blue part, and we have kind of 6 phylums. We said Firmicutes, as you can see here in the bottom, Actinobacteria, Bacteroidetes, Fusobacteria, for instance. If you compare on the right here, I don't know if that will, yes. If you compare here, this is the gastrointestinal tract, this is the gut microbiome, which is quite rich, for instance, in Bacteroidetes or Firmicutes, this is the proportion. And then if you compare to the vagina microbiome, it's completely different. If you compare to the mouth, it's completely different. If you compare to the penis, it's also completely different. So we can see that at different parts of our body, there are a different composition of microorganisms that they are doing different functions. What are they functions? Well, this is something that we are trying to understand and to really dig on detail. So based on all these kind of different compositions of the gut microbiome, or sorry, the microbiota, we are going today just focusing on the gastrointestinal tract. So only focusing in this part. There is a lot of discussion about this terminology. Some of you might have heard about that. When we try to understand the microbiological ecology, we try to simplify everything into these simple terms: eubiosis and dysbiosis. What does this really mean? Dysbiosis, normally it means when the microbiota is disbalanced. That means that you have a higher proportion of bacteria that maybe they can be harmful for your body, that they are in a higher prevalence, on a higher relative abundance compared to the others. So normally they say that when you have an eubiosis status, means that you have a really balanced microbiota. You have the kind of the same proportion of microorganisms, and they are all of them living together. So it has been associated in the past that when humans have a higher eubiosis in their gut microbiota, they have a lower prevalence of diseases. Basically, it's everything related with a better health. However, right now is like a big discussion in the field if really this dysbiosis or eubiosis status really exists, because we have discovered that the gut microbiota has a large intravariability. So that means that if I compare myself with somebody else, both of us could be in the same level of healthiness, let's say that, but our gut microbiota could be completely different. Because basically the most important thing is that the function of this gut microbiota, for instance, they are really involved in carbohydrate metabolism, they can reach this effectiveness in carbohydrate metabolism via different composition of microorganisms within the gut. So it's kind of when you open your wardrobe and you see different trousers. The goal of the trouser is to cover your legs. So you can have a tiny, beautiful, ugly trousers. At the end, it does not matter. The function is the same. It's covering yourself. So basically, the body is organizing the microorganisms in a way that they are doing their function, and they don't really care about if it is replicable between individuals, because they have tried to find if there is a core of microbiota, microorganisms, and they could not find it. So that means that it has a large variability. And also, really important things is like the gut microbiota change a lot over the day. That means that in the morning, you can have a higher relative abundance of certain bacterium, and in the night, you can have a lower abundance of those bacterium. So there is a circadian rhythmicity between the days. Of course, it makes sense because you are eating different times of the day, and it does not make sense that the same microorganisms will be alive during the whole day. So we see that this is changing a lot across the day. Of course, also across the week. From Monday to Friday, we try to eat healthy, because we are working and we try to be good persons, let's say that. But then on Fridays and Saturdays, we really like to go to take dinner outside, to hang out a little bit. And this is affecting the microbiome. So if you measure the microbiome on a Monday, it's going to be affected by the work or the things that you have done over the weekend. So also it's important to understand that this is quite plastic. It changes a lot during the days and during the weeks. So you can imagine that so far the best technology that we have to measure the microbiome is collecting stool samples. And of course, we need to understand that we are taking a fecal sample. So that means that this fecal sample might be representative of the gut microbiome or not, because when you have a feces, the feces is really, your body is really eliminating the things that are not useful. So also we have an overview that might be related or not to that one. So we have a single snapshot about how the gut microbiota composition could be in your body. So basically, one of the most important things about why this topic is so fascinating is because those microorganisms, they have a large impact in your body. It has been a lot of evidence that have impact in your brain system, heart, muscle, adipose tissue, liver, and kidney. But the most important thing is that those gut microorganisms are not affecting those organs just because of their presence. They are affecting those organs because they are producing metabolites. And this is crucial. We need to understand what are the metabolites that those microorganisms are producing in order to impact the metabolism. Otherwise, we are not understanding the basics, and then also we cannot develop further strategies to really impact overall health. But what is the applicability? Everything started like a long time ago, for instance, when we were starting working in this topic, it was approved by the FDA fecal microbiota transplantations for treating Clostridium difficile. So this is an infection that you can get in the hospitals, and this fecal microbiota transplantation has shown a super high efficacy in reversing the Clostridium difficile infection. So this is already applied in humans and is already approved. So this is already opening the question that if we are able to transplant the feces from somebody who is healthy to somebody who is not, maybe we can have an impact in the metabolism. Of course, this is not something that you would like to do on a daily basis, and this is why people or the community has developed the probiotics, which is live bacteria, prebiotics, which means the fibers, the carbohydrates, and basically the substrates that these bacteria need to grow, and postbiotics, which are the metabolites that they produce. This is what I was saying before. We need to understand the metabolites. So if we have a bacteria that produces a specific metabolites, if we are able to isolate it and to target the gut, we have already a way and a mechanism of action. So really working in this section has opened many different questions and many different opportunities. As we said, there are many axes that has been discussed. One of the most famous is the gut-brain axis. Another, the gut-liver axis, is quite famous and well-established, gut-lung axis. And for instance, I'm really working in the gut-muscle axis. So what is the connection between the gut and the skeletal muscle? To do so, we did an experiment that took us 7 years, that was published last March. Basically, we were thinking if we were able to transplant the feces of somebody who is super sportive to somebody who is sedentary, we might be able to really replicate the phenotype of this sportive person. Of course, we cannot do this fecal microbiota transplantation, so we try to understand what could be the bacterium. So here we have a cohort of older adults, and we found this bacteria, which is called Roseburia inulinivorans, and it's called like that because inulin is a fiber, and this bacteria mainly consumes this fiber. The vorans devour this fiber. This is what is called inulinivorans. We found out that just in older adults, there were a group of people that they have this bacteria, as you can see here in the positive, other that they did not have it, and we observed in cross-sectional levels that they have a higher muscle strength. Just these adults, this was an innate muscle strength. They were sedentary. We went to another cohort of young, healthy people, and we observed that people who have low amount, intermediate, or high amount of this bacterium, they have a higher muscle strength. So the higher is the relative abundance of this bacterium in the gut, they have a higher muscle strength and a higher VO2 max, which is the maximal cardiorespiratory capacity. Then when we compared the both cohorts, we observed that this cohort, the Roseburia unilivorans, this bacterium, really decreases with age. So this is the older adults, and we see that this really decreased. So we did something very simple, which was to take this bacteria and to give it to mice to really prove causality. We took healthy mice, we gave this bacterium, the Roseburia unilivorans, and we observed that this bacterium was modulating the amino acid biosynthesis in the bloodstream and was increasing the muscle strength by a 30% without doing any exercise, these mice. So for us, that was quite shocking to find out that this was possible, and also we observed that there was a shift in the type 1 to type 2 fibers. And this is a specific gut bacterium in humans. This bacterium is not present in mice at all. Then this is an experiment that we are doing in Leiden right now, because I am working more in obesity and in metabolism. So we are doing an experiment where we are taking old mice, because we are focusing now on sarcopenic obesity. So it's the loss of muscle mass associated with obesity. This is an experiment that is ongoing. It's going to be finished next week, but I'm super happy to show some results. Here we were comparing 3 groups, placebo, Roseburia unilivorans, the strain that we were using, and another strain that we can use, that maybe we can use for future probiotic products. The preliminary data that we have so far is that this bacterium, the Roseburia unilivorans, prevents age-related loss of muscle strength. So even though the mice are aging, we are, as you can see in black, they are losing a little bit of muscle strength, and we are able to preserve and also to increase the muscle strength by 17% in the best cases and 12% in other cases. Then when we repeat the analysis, so in the grip strength relative to the limb mass of the mice, also we see that this effect is persistent. So now also we are going to dig on that, but I think this is something really interesting that also could be applied. So when I got the invitation to come here, I was starting to think about what could be the applications in rheumatoid arthritis. And then I found out this exciting review that I really recommend to read. It's really inspiring, where they really say that the risk of sarcopenia, as you can see here is a prevalence of 25% in individuals with rheumatoid arthritis. It's quite high, this problem of the sarcopenia, as all you might know. So then I went to a public repository biobank, and I started to see if, with the open data, this Roseburia unilivorans is present or not. Then I found two interesting diseases. One of them is not related really with rheumatoid arthritis, but this, I know that there are some people that are interested here, which is the syndrome of chronic fatigue. And we can see here with these LDA scores that they have a lower relative abundance in all these patients. And of course, also in patients with fibromyalgia, this bacterium is not present. It's like the relative abundance is quite low. So therefore, this therapeutic opportunity that we are observing with these Rheumatology olivorans might be an interesting therapeutic target for patients maybe living with rheumatoid arthritis. So I have 4 home messages. The first of one, the gut microbiota is highly promising field, but it remains in its infancy. Our understanding of its impact on human health is still limited. We need way more research to really understand how that is work. Many microbiome-based products lack robust clinical evidence, and this is important to know, that most of the probiotics that are in the market are expensive placebo. And the Rheumatology olivorans, the bacterium that we have observed, might offer a novel approach to improve muscle strength in all conditions related with sarcopenia. I would like to thank to all my team. This is the people of my lab, and also the mentors and the funding agencies supporting this research. Thank you.
Thank you very much. We will go straight to the next speaker, Dr. Christopher Marty, a physical therapist from the UK. That he will talk about the microbiome in rheumatic and musculoskeletal diseases. What's the state of the art?
Thank you.
The stage is yours.
So Chris, before you say that, I have to say that please respect when there's a sign, no photography, so not to take photography. Thank you.
Okay, thank you. Good morning, everyone, and delighted to be here. Wanted to say a huge thank you again to the Organising Committee and Congress Committee for this, and actually giving a perspective here as a clinician, in between my colleagues here, Borja and Jose, who are researchers, and to give an aspect of why this was critical for me in practice with my patients. These are my disclosures, no financial, but I am involved in a UK charity and a Brunel University research group, which is exciting. So I'd like to talk through, really a brief overview following on from Borja there around the gut microbiome and its relevance, of course, with rheumatic and musculoskeletal diseases. Crucially then, as a health professional in rheumatology, really trying to see what value we can add in this aspect, exploring lifestyle factors, and then general considerations. And I'm delighted to see lots of familiar faces in the audience, but crucially here, we've got an eclectic mix of professions, and I think this will really be key as I go through the presentation. So, as has been mentioned there, the gut microbiome represents a full array of these microorganisms, and it's the largest reservoir of which is within the gut. It's complex and diverse, as we've just heard, and also we can think, again now comparing to the Milky Way, about those trillions of bacteria and cells which make up this composition. But really, in clinic, I was thinking, how did my interest spark this? And it was firstly with the patients. Of course, this is what we all have in mind. And it was speaking to patients, my rheumatic diseases patients, axial spondyloarthritis patients, and they were saying to me, Chris, I've changed my diet, and suddenly my joints and things are feeling much better. My fatigue has reduced. And I was thinking, well, okay, that's fascinating. Brilliant. I'll speak to some rheumatology colleagues. So I spoke to some very eminent rheumatologists and saying, what advice do you give to the patients? And they said, well, actually, Chris, we know that the evidence is emerging, and I'm not confident in saying specifically this is what they should be having. So it's almost a trial and error. And it then made me think there are so many unanswered questions, because we can say which gut bacteria might start or stop inflammation and which gut bacteria might reduce inflammation. And crucially, how do we get this messaging across? I think when I'm speaking to patients, we know we have a real mixture of people's understanding of their condition, health literacy, and actually, whilst we're talking about certain bacteria there, how would we actually relay that communication to make it understandable for our patients? And critically, this dysbiosis concept is what we start to see with each of these patients. So we know that what we hope for is a unified, balanced, homeostatic gut microbiome population, being mutually beneficial for us. And if this is not off kilter, then this could lead to negative changes in the metabolism. We know that there's microbial dysbiosis is the imbalance of the structure and the function of the gut microbiota. And the common problem in this era is that it's caused by lots of different things. We know bacterial infections could impact it. We've just heard that there's changes day to day and throughout the day. Changes in diet, crucially, will be key. But also the environment, as we've alluded to before. So that means, again, the mechanisms in the environment where we are looking potentially where people live in rural areas and urban areas and what the atmosphere might do to us, but also the drugs. So the medication that we're trying to prescribe for patients could also have a negative impact in this set. But crucially, the emerging evidence does exist within the gut in MSK and rheumatic diseases. So this dysbiosis and altered intestinal permeability, so synonymous with the quote, leaky gut, could induce chronic activation on inflammatory processes. And we know that this is complex interplay with genetics, the environment, and the immunity. And of course, when we're thinking about these patients, we have a huge genetic component oftentimes. And we know that this is not always fully understood. From my perspective, though, particularly when I was looking into this, I was really careful around the clinical significance. And actually, some papers have suggested not to overestimate that, and potentially it's too early to make far-reaching conclusions. So I just want to, in the short time we have here, just touch on a few of the RMDs here and start with the spondyloarthropathies. And of course, a lot of you will recognize those extra-articular manifestations that are within spondyloarthritis. So we know that we have skin psoriasis, often acute anterior uveitis, but also within the gut, we know that there are changes principally with Crohn's disease and ulcerative colitis. So it's suggested that actually the dysbiosis of the gut microbiome may be a contributing factor to the pathogenesis of this. I'm conscious that there are a few trains of thought around what may be a driver for the onset of inflammation in these genetically susceptible patients. But it's really interesting then when we think about that inflammatory bowel disease that's underlying, because we know that some people have visible symptoms, signs and symptoms, but actually at a subclinical level, we know there's a prevalence too. And it's this feature that we kept seeing in the literature regarding this increased permeability. And there's a thought here that the associated mechanisms, some of which Borja was mentioning there, whilst they not all have been well defined, may be that HLA-B27 is a driving susceptibility factor. But again, we know gut inflammation is strongly associated with spondyloarthritis and amplified by the high prevalence of IBD. But this gut-joint axis, and actually it's interesting that Borja was moving into the gut-muscle axis. I'm really interested in that gut-joint axis and how the specific cytokines, for instance, may impact and may even be tissue-specific. So it's really quite interesting. But of course, moving on from the spondyloarthropathies, you can start to see that it is in the literature for other conditions. So rheumatoid cachexia and sarcopenia, as was just mentioned there, is really important. But we can start to see that studies have suggested that this dysbiosis is also there in rheumatoid arthritis. Of course, a chronic inflammatory disease, which could further induce this chronic activation of those innate immune cells. Again, looking at these patients, the RA patients were exhibiting altered gut and oral microbiota. Again, that's, you saw the diagram there, seeing different areas of the body that we have these specific reservoirs of these species, and increased pro-inflammatory bacteria. So, similar to SPA, there's growing evidence of the gut-joint axis in RA. And again, these RA patients may be have increased intestinal microbes. But again, the presence of this may then correlate with worse outcomes, and interestingly in this paper it suggested that worse clinical responses to treatment with the most commonly used DMARDs. And again, I think that opens up our eyes to, certainly in the clinic, to suggesting why we might get some people who are or aren't responding as well as we would like. But it's not just the typical inflammatory diseases that we're conscious of here. Now, I know osteoarthritis is becoming much more of a profound disease with low-grade inflammation and systemic factors. But there has been some findings within osteoarthritis. And here I was quite interested in this. The DNA of gut microbiota can be found in the synovium of osteoarthritis. That essentially means that genome, and therefore the sort of microbiome umbrella term for that, but possibly linked to the movement of bacteria from the gut into through the joints through the blood. So these findings were found in the human cartilage, suggesting there's a similar sort of trafficking of the bacteria from the gut microbiota physiologically between the gut and the bone. Of course, I'm sure you'll find this fascinating. Not least when I see my patients, anybody who's coming in with, again, maybe other musculoskeletal issues associated with osteoarthritis, perhaps things like tendinopathies too, we're conscious of the obesity and metabolic syndrome that we know is happening and linked to this. And of course, then we can think about how this might be linked to the gut dysbiosis and have negative effects. Also, though, of course, caveating a lot of this, I was going into the literature here and found myself asking more and more questions. And we need to then consider whether or not these changes in the gut microbiota change, of course, to age, body mass index, diet, exercise, and, of course, hormonal background. But what can we do as HPR? And I think, of course, alongside our eminent researchers, we can start discovering more about this. But right now, next week, when you go back to see patients, what can we start doing and start considering? And so for me, it's doing what we do best, looking at the non-pharmacological treatment options that are out there and emphasizing diet, sleep, and exercise. But of course, with caveats that I'll come on to. So crucially, we will all be talking about this in some guise because we need to be ensuring that this is important and this message is getting through to our patients. But the effects of lifestyle on the gut microbiota composition has suggested there is a possible modulatory therapeutic effect. But again, the evidence is still, in some spaces, insufficient. But of course, because these components are key to a healthy lifestyle, we can infer that we can start having these conversations. Thinking about the fact that one goal within R&Ds is to control the inflammatory response, immune mediators are therapeutic targets, for example, for IBD, again, we can start to thinking about a focus of the treatment. So if we specifically go into diet, and of course I'm not a dietitian, I'm very mindful that I would talk about a healthy diet, but with the caveats to linking with my dietetic colleagues and my wider professional colleagues. But we know that diets do have a huge impact on this. We know that this can be attributed to nutrients that can alter the microenvironment there. The rationale, though, is that there's lots of different diets that are purported to have the beneficial effects. Hypercaloric diet, the Mediterranean diet, which of course many of people will be talking about, and potentially the ketogenic diet, suggesting possible anti-inflammatory effects, though variable data. And I'd really be interested, perhaps after this talk, to catch those that are interested to take this conversation further. It was really interesting, the comment on the probiotics, because my concern with these was that generally classed as a food rather than medicine, and though oftentimes then that means they don't go through the same rigorous process as testing medicines do, and therefore we can't always be sure that the product actually contains the bacteria that's stated on the food label, the product contains enough bacteria to have an effect, or that the bacteria are able to survive long enough to reach your gut. So again, being very cautious again about what we may want to suggest. Now, sleep, all of you got up early and managed to join us first talk. We know that sleep is important, but in busy lives, oftentimes that can be compromised. But sleep length has been demonstrated to have a significant effect on the composition of the gut, and short sleep duration is thought to promote gut microbiota abnormalities. We know without enough sleep that people tend to overeat or choose unhealthy foods. Sleep deprivation, therefore, affects the body's release of different neurochemicals. And of course, the chronic sleep loss has been linked to having an increased risk of obesity. And again, when we think then about abdominal adipokines and that pro-inflammatory state that people can get in, you can see that this starts to develop potentially a vicious cycle. Moving on to exercise, I'm looking across the room with HPR. This doesn't really need talking too much, but it's really exciting that actually I think we know that the phrase exercise as medicine is something that should be purported more often and more readily. And this further supports the thought that exercise has proposed anti-inflammatory properties and therefore is an important part of standard care for RMDs. It's also thought then that there is an impact on what we can do to improve our gut health. And I have to have a nod to the recently updated recommendations, knowing that, of course, physical activity reduces morbidity and mortality associated with these non-communicable diseases, positive impact on many, many things, and that we should be promoting this. And actually, as part of our lifestyle conversations, we can be discussing that more broadly. So some general considerations from my perspective as a clinician treating patients each week. The gut microbiome, I think, represents an opportunity for multidisciplinary involvement and research. As I mentioned, we have many colleagues here, nurses, physiotherapists, dietitians, and researchers. And it's important for us to get together and start thinking, what are we seeing in practice anecdotally, whilst the evidence is also emerging. So I would say to consider the influence of these things in practice, consider the patient's predisposition potentially for poor gut health, without being able to necessarily pinpoint whose gut health is poor. You might begin to start thinking about that assessment of the wider obesity and metabolic syndrome risks. But also consider the patient's understanding of gut health and their disease. That is crucially important because we want to make sure we have a shared understanding, particularly when we're thinking about shared decision-making. And we want to reduce and remove any unnecessary jargon. And I certainly think within this topic, there's a risk of getting into the weeds with things. But also consider your scope. If you are not a specialist, and I certainly think a dietitian, somebody who's used to delving into the evidence in this area more broadly, then I really would be careful of that, just because it's quite easy potentially to start offering treatments that actually could have a negative effect on somebody's wider health. So the important thing is here, collaboration to speak to colleagues. I have to state that we can't overestimate the clinical significance, but this is my starting point. It was being a curious clinician, and I think that's something that we ought to be doing. Remaining mindful of limitations, but engaging with our colleagues. Considering your communication with this topic, and then again, reviewing patient resources and education resources. So I just have to say, here in the United Kingdom, there are several patient partners, charity organisations, which do so much for patients. And whilst evidence might not be conclusive, they are helpful at trying to support patients into exploring these different aspects that might impact and reduce the burden of their disease. So I just want to say that last year I started an early research group with Brunel University, so a mixture of some clinicians and some researchers, and we're starting to ask these questions, taking that clinical relevance into this, and would hope that if anybody is interested, feel free to send me an email if you're wanting to potentially think about some collaboration. And at that point, I will finish on time and say thank you, everybody, very much for listening.
Thank you, Chris. And the last presenter is José, who is a professor of medicine and rheumatology. Thank you and welcome.
Thank you very much, and thanks to the organizers, particularly for putting it all together, to Borja and to Chris, who made my life easier. You okay? Okay, good. She got excited about what I had to say, I guess. The issue is that I've been doing microbiome research in the context of inflammatory arthritis for almost 20 years now. The white hair doesn't come for no reason. But I'll show a lot of heavy data, but I'm going to try and then download it to the practitioners and see what kind of data will potentially be helpful in trying to transform clinical management in inflammatory arthritis itself. These are all my disclosures. I get a lot of funding from the NIH. Hopefully that institute is still alive in the next couple of years so we can continue to do our research. And I'll go through microbiome-based therapeutics. What have we learned from oncology, but also other work that has been emerging from some of the people in the audience. Short-chain fatty acids, this idea that metabolites and not necessarily microbes themselves may be relevant as modulators in arthritis and other autoimmune diseases. and how we can think or start thinking about precision medicine utilizing gut microbiome for diagnostics and treatment prediction. Okay, number one, therapeutics. What have we learned from the cancer field? If you look at what the cancer folks have been doing, they're much more advanced. I'll take you back about 7 or 8 years ago. This first study looking at whether or not the baseline microbiome of patients that are about to be treated with immune checkpoint inhibitors had any correlate with future response, okay? So what they did is that they took, for the most part, fecal microbiome, they initiated therapy, they got a tumor biopsy, and then they repeated microbiome later, they did all sorts of analytics. And what they found is that if you are not responding to the immune checkpoint inhibitors, you were more likely to have much less diversity in your gut. So the amount and quantity and quality to some degree of your microbes were decreased. Didn't really matter what kind of microbes we're talking about, but if you took a few of them, you could see that you would remain progression-free in cancer if you had a low abundance of certain microbes, okay? So that's the concept. What did they do with this data? Is that they took microbiota of patients that responded and not responded, and then they humanized mice with the cancer. Then they treated, and they asked the question, did you do better if you were a recipient of microbiota from people that had responded to the immune checkpoint inhibitor in the first place? And the answer is yes. Mice that received responder treatment were able to decrease their tumor size. And you can see this in imaging studies as well. So proof of principle that the microbiota has some implications in treatment response, at least in cancer. They went on more recently to do clinical trials already with fecal microbial transplantation. And what they did was, what happens to people that failed the first course of immune therapy, and you combine that microbiota from people that have responded to another course of immune checkpoint inhibitor. And there was a benefit for about 40% of people that had melanoma and were receiving both the FMT and the immune checkpoint inhibitor, rescuing a prior failure with treatment. Again, proof of principle that now, at least in a phase 1, phase 2 trial, and this is published in Science, you could actually improve outcomes of conventional therapy in the oncology group. And what they've done right now, and this is published a couple of months ago, is that they're pursuing phase 2 trials already. And they're pursuing phase 2 trials mostly on advanced cancer patients comparing fecal microbial transplantation or placebo. They typically now do it with capsules that contain microbes, and they compare the combination therapy to the standard of care treatment. And what they found is something interesting. A previous model, if you look here, they had the notion that you only needed to engraft microbes from donors for you to respond to the therapy. With these trials, what they're finding is that that's not sufficient. What you're doing with an FMT approach is that you're replacing the bad guys. And once you not only engraft the good guys, but you eliminate the pathobionts of the bad guys, that's what's going to take you to respond to at least immune checkpoint inhibitors. Again, out there, ongoing phase 2, phase 3 clinical trials. This is not science fiction. It's happening, at least in the oncology world. In the psoriatic arthritis world, we have Maya sitting here. She's conducting really amazing good work in Europe. This is the first ever FMT trial in PSA. It's a small number of patients, but we're learning quite a bit. This is Flora. The idea was to transplant either sham solution or FMT. It was a one-time only, so we can discuss design and we can discuss approaches. But what you see was something interesting, that people that received the fecal microbial transplantation with PSA ended up doing worse than placebo. And the question is always, are we talking about a component of people that are doing worse, or we're asking the question of some people developing reactive arthritis because the donor FMT came from people that led to inflammatory arthritis down the road. Maya and colleagues did further work. She asked the question of what is it about the people that ended up responding to the FMT that was different? And a couple of things were different. Number one is that the intestinal permeability on people that had responded to FMT was lower at the end of the trial. And in a follow-up study, she also understood that short-chain fatty acids, again, very important metabolites from the microbiota, correlated with both engraftment, but also achievement of ACR20 or other outcomes in psoriatic arthritis. It's happening, we're learning, we really need to understand who are these donors, what kind of microbes we're dealing with, and whether or not this can be ready for clinical work. An abstract that's being presented at this meeting is the question of probiotics. Someone raised the point of probiotics. First ever trial, double-blinded, randomized controlled trial using probiotics in psoriatic arthritis. Patients with moderate psoriatic arthritis, they were not the most active people. They were randomized to either placebo or probiotics. And what they found is that probiotics were not better than placebo. But the other take-home message is that if you are on a study that's including probiotics, even if it's a blinded study, you see a lot of either probiotic effect or the fact that patients that know that are on probiotics, even if they're in placebo, they may get a placebo effect. That's a very interesting take-home point. And I don't know how to explain this other than maybe the notion from our patients is this is something magical, irrespective of what you were receiving at that time. And when I see this all the time, mind that a lot of the outcomes from our patients are pain, are function, and some of them are subjective. So the placebo effect of probiotics shouldn't be discounted. Now, there are a lot of drugs in the pipeline. There are drugs for cancer, as I just discussed, and these are from big pharma, okay? There are drugs that are being developed based on the microbiome for ulcerative colitis and Crohn's disease as well. And as it was discussed, there are 2 FDA approvals, not only FMT, but now there are capsules and there are suppositorium that have been FDA approved for the treatment of C. diff colitis. The point being, microbiota is a clinical reality out there, true for infectious disease. We'll see how it boils down for inflammatory diseases. All right, metabolites are important, we were told by Borja, and they are. And they modulate inflammatory arthritis. And I'll walk you through quickly about what the state-of-the-art on research is. Number one is the notion that short-chain fatty acids are probably the most relevant ones. Propionate, butyrate, acetate, very important because they have immunomodulatory effects, mainly through the activation of lamina propria regulatory T cells that now tend to control or downregulate inflammation both locally or downstream. So keep in mind short-chain fatty acids, keep in mind the notion that they have immune regulatory properties. I'm not going to bore you with animal models. I'll tell you what this animal is. We did the work. This is a psoriatic arthritis model that has arthritis, has osteoporosis, and has psoriasis. It doesn't really matter. What matters to us is, can you reverse the phenotype of this PSA-like model simply by gavaging these animals with short-chain fatty acids? And that's what we did. You see that the short-chain fatty acids themselves, right here, inhibit the differentiation of these osteoclast cells, and those are important because those are the cells that chew up bone. And if you chew up bone, you end up with erosions. Okay, so we rescue that, and we also rescue the osteoporosis. Didn't do anything else with these mice. So their osteoporotic bone, both trabecular and cortical, became much better in these animals only by being fed with butyrate or a cocktail of short-chain fatty acids. This is published data. This is fun data, just as a proof of principle that you can rescue a phenotype of mice. It's true in arthritis. Again, I'm not going to bore you with the details, but any animal model that you expose to short-chain fatty acids gets better, irrespective of treatment, if you incorporate either short-chain fatty acid, acetate-propionate, but particularly butyrate. It's true in a collagen-induced arthritis model. It's true in a serum-induced arthritis model. No details. Conceptually, this might be true. We went ahead and asked the question, if in fact you can go out there and look for monozygotic identical twins that has one sibling with rheumatoid arthritis and the other sibling being unaffected, it follows that there must be an environmental factor that may modulate disease. And that's what we did. It's a cohort in the US, it's in another cohort in the UK, and we asked the question, is the microbiome any different? And lo and behold, some of the microbiome was different, but most of it was not. What was different was the levels of short-chain fatty acids. And granted that some of these patients were treated, granted that this is a small number, but this is arguably the largest twin cohort looking at rheumatoid-affected twins and unaffected siblings. So the question is, they're there, it's not being modulated by genes, can we do something about it, right? And that something has been done. Reminder that short-chain fatty acids are byproducts of microbial metabolism of fiber. If you eat high-fiber diet, whatever that may be, you need to have certain microbes to convert the fiber into short-chain fatty acids. This is data from the Germany group. They did just that. High-fiber diet on rheumatoid patients, what happened? The short-chain fatty acids went up, and the pro-inflammatory cytokines went down. So they're just proof of principle in humans that there are some modulatory effects of these high-fiber diets in rheumatoid arthritis. The NHANE study saw this as well. If you have a chronically stable diet with high-fiber diet, your chances of developing rheumatoid arthritis is significantly lower, okay? Clinical evidence, although early, epidemiological evidence that short-chain fatty acids may have some modulatory effects in rheumatoid and other inflammatory arthritis. This is data from Claire in Montpellier, if I'm saying this right. I don't know that you can take pictures of this. This was presented at ACR, so I neglected to reach out to Claire, but just to show that this is a really well done study, doing what we were just describing. If you randomize people, actually, if you randomize people on stable DMARDs and you only give one half of the patient's fiber, inulin in this case, do you do better in a short period of time? Bottom line is, in this proof of principle study, is that they do, mainly if you're on methotrexate. So now the question is a little different. Now the question is, what does the microbiome do to the drugs we prescribe? Do you modulate the way we absorb it? And in that case, do we modulate the downstream effects of methotrexate? I'll show you a couple of slides in the next step. We've done some of this work. We did it differently. We're doing it differently. What we're doing is not high-fiber diet, but we're giving the short-chain fatty acid to patients with rheumatoid arthritis from the get-go. So we're not waiting for people to have the right microbes to convert high-fiber diet into short-chain fatty acids, which is providing the butyrate itself. And we're seeing some improvement in the methotrexate response. This is work in progress, but Rebecca, depicted here, is doing a little bit of that work with us. We'll see what the answer is. So lesson number 2 is that butyrate and other metabolites modulate downstream effects of the gut microbiome in inflammatory arthritis. We'll see how that transforms or not clinical care. And the last one in the last couple of minutes, and I will skip a few slides for the sake of time, is that we can use the gut microbiome for diagnostics now, and also to predict treatment response. This is data from the IBD world. What they found is that you can detect people with IBD, both Crohn's and colitis, if you have certain microbiota in your gut. So the microbiota can serve as a biomarker for diagnostics of IBD, and then you can compress that trillions of bacteria into only 10 specific species, make it into a biomarker kit, and then be superior to fecal calprotectin, which is very important because fecal calprotectin has modulation based on use of NSAIDs and other medications. We did something similar. The question is, if you look at patients with psoriatic arthritis walking down the street with no symptoms, and they have an elevated fecal calprotectin, how many of them have IBD? It's about 3 to 4%. And then we did microbiota studies on these patients with or without IBD. What did we find? That not only certain microbe signatures can differentiate IBD from PSA with IBD from PSA without IBD, but also the fact that a cocktail of bacteria were superior in differentiating those two cohorts compared to fecal calprotectin. This is very important, again, because a significant proportion of our patients with psoriatic arthritis are on NSAIDs. And because they're on NSAIDs, the fecal calprotectin is not reliable. Okay, one slide on methotrexate response, and I will leave it at this because we're running out of time, is that we asked the question on people that have new onset rheumatoid arthritis. Is the gut microbiota predictive of response to methotrexate? And that's what we did, and what we found is the answer is yes. If you look at the gut microbiota and you apply some machine learning algorithms looking at the genes in the gut microbes, you can differentiate and predict who's going to respond to methotrexate. And this is published a few years ago. We asked the question of what that happened. The answer on this slide is that methotrexate is being metabolized by certain gut microbes. And you have a variety of gut microbes metabolizing methotrexate. But the point is that if you have one of those, the methotrexate gets metabolized, doesn't get absorbed, and it follows that shouldn't have a clinical effect. Okay, so I'm going to skip this just to say that metagenomics and metabolomics can be used as diagnostic biomarkers and predict treatment response. And I'm going to summarize by saying that there's emerging data. Whether some of these will be clinically relevant or usable is a different story, that the microbiome is being exploited, particularly in oncology already and in infectious disease, but also in our diseases, and they can be used for precision medicine as well. And with that, I'll thank all the people in my lab and my collaborators, and we'll take questions, I think, later in a couple of minutes. Thank you for your attention.
Thank you, all of you. Very interesting, exciting, and of course, still a lot of questions need to be solved. But now we have time for discussion with the three presenters. You have the possibility to raise questions, and also there are 2 questions in the app. So please remember to present yourself, your name and where you come from before you ask your question. But I think, Khadija, you will start out first. Yeah.
Yes. If I may, I wanted to ask this even before the presentation. But it's very fascinating. It's, as you say, it's a very big word that we still have to study, but clinical implications are already there. We already see some of clinical implications and the positive effects on when we work on this, on the microbiota, specifically the gut microbiota. My question to all of you was, coming back home today, tomorrow, whenever you go back, where should we start? I'm a nurse, we have OT, we have physical therapists, we have very different background. We might not be nutritionists or dietitians. We know that lifestyle and all the aspects that we discussed are very important. What is, from your different perspectives, you all have 3 different perspectives, what is the main important aspect and simple strategy? Because we need simple strategies to take back home.
I'll start. I think the simple strategy, and I face this all the time. 2 simple answers, and they're not easy to attain. Number 1 is high fiber diet. You would get dismayed about trying to understand how many people do not incorporate fiber in their diet, in their daily diets. It is astonishing. So it's easy. Ask ChatGPT what a high fiber diet looks like. It truly is what I tell my patients. And just follow that. You don't need a nutritionist or a dietitian. Number 2, lose weight. Because weight loss is all-encompassing. You do everything you do for cardiovascular risk. You do everything you do for lowering cholesterol, increasing survival, but also for joint pain. If you are overweight or obese, I promise you that your knees and your ankles are not happy. And so if you say those 2 things, you've made a significant progress with the treatment of your patient.
Thank you. Yeah, my point is a real practical one. I would hope that you could leave here taking this into your departments, into your teams, and saying, hey, I want to raise this as a topic for debate, a topic for discussion, and see where everyone else is. Because practically, that's something that we've done here in the UK, and it starts that conversation going. And also, crucially, I can see there's been some other questions, but crucially, it allows us to ensure who the key partners are in this conversation and align that shared approach so that it's standardized. Because I think, crucially, patients will see different individuals in the team, and we want to ensure we've got a unified message.
Yeah, well, very difficult to add to those main messages, but for me, one of the most important is to move, and especially we need to ask to the patients what are they really like, or what type of exercise they really like, or what type of physical activity they like. Because we have seen that just moving at what we say zone 2 training, which means is walking at a speed that you can talk with a partner for a little time and then you can build on that. And this is reducing hypoxia in the gut, and therefore is restoring the gut barrier integrity, and also is helping the gut microbiome. And this, we have seen that this has a direct impact. So just move a little as you can do every single day, and just build on that will help your gut integrity a lot.
Thank you. I noticed that 2 in person having questions. Yeah, please.
Hello, Rini Gene from the Netherlands. Thank you very much. It was very clearly presented, very good. I could understand most of it, which is unique for this. I have the following question. I'm collaborating with a colleague, and he says he has a biomarker of post-exertional malaise. And he's testing it, and I'm collaborating because I think it's interesting to know, because it would be a biomarker of energy levels as well. And he has a patent for it, but now I understand, Borja, that Roseburia inulinoforans also is consistently depleted in chronic fatigue syndrome. So that also looks like a kind of biomarker for post-exertional malaise, because that's the primary criterion, isn't it? So it is already there.
Yeah, one important thing is that we have done epidemiological data, and we have seen that this abundance of these bacteria decreases with age. So in the moment of 65, 70 year old, really disappeared. So it's merely coincides with sarcopenia. But also now we are doing studies in old people, and we have seen that Rheumatology unilaboran is not there, but there is another gut bacteria groups that also are relating with muscle strength. So this is why the importance to go to the metabolites. When we go deep on that, we have seen that it's related everything to amino acid metabolism. So it seems that if you have an impaired amino acid composition in the gut, it's really affecting muscle function in that way. So basically, I would say maybe Rheumatology unilaboran is one of the protagonists of the characters of the story, but I think the underlying story is amino acids. So I would say that if we are able to measure amino acids in the gut, we might be able to really see the mechanisms behind. It's a little bit something that Jose has shown with short-chain fatty acids. If we move to that direction, the biomarkers, in my opinion, will be amino acids within the gut, something that we should measure.
I think it's important not only for diagnostic purposes or something, but because we can perhaps rely on it and say, for this person, another kind of physical therapy is needed than for people without those problems, like gradual physical exercise or not.
Yeah,
so thank you.
Thank you to you.
Next one, please.
Thank you very much for this insightful and very exciting talk. Denislav Orlinov, physiotherapist from Iceland. I always enjoy to bring that microbiota to my classes when discussing with the students. And somewhere I read that there is a reason because of the disease onset related to anaerobic bacteria. And this, for addressing that, physios can use the aerobic exercises for increasing the circulation of the gut, and it will help to decrease the anaerobic bacteria and increase the aerobic one. But now I'm reading something else. It's not always the case. So what's your opinions that? So it's the aerobic exercise would be a therapeutical option.
I could start with that. Potentially, research colleagues might have another lens. My thought would be, Dennis, we need to get better at prescribing exercise, period. And so the 4 pillars around, I cited the EULAR recommendations, of course. I often see patients who are doing lots of cardiovascular exercise and then missing out on strength training. People who are doing flexibility exercise and actually are missing out on other aspects. And so I think at this stage, my stance would be we just need to prescribe exercise, prescribe the full remit of exercise and get people feeling comfortable with that. I think this is a really exciting prospect, though, that there's an opportunity to hone in on more targeted research, and I think more will come out. But for me, I think, again, very much a clinical, practical stance. I think we need to make sure we're getting that clear message broadly across the board. Yeah,
I really agree. But also, I think we can learn a lot about what in other fields they are doing. For instance, the bacteria that I presented is strictly anaerobic. So
that's why, yeah.
That message is sometimes like we need to upregulate one type of bacteria. I think it's not working in that way. So what we see is that just moving, for instance, if you do moderate exercise intensity or high intensity exercise, you have different impact in your gut. The main reason is because you have an aorta, the mesenteric aorta, which is really feeding the gut with blood. And if you are doing high-intensity training, you have a vasoconstriction in this aorta, so you are inducing anaerobic conditions, so you are changing the microbiome. So this is why you need to combine 2 types of exercise. And something that is important, we cannot understand gut microbiota without understanding the gut physiology metabolism. So if there is a gut leakiness there, of course, it's affecting the bacteria, and we can reduce this gut leakiness by doing aerobic exercise, for instance. So what evidence says is, in terms of your gut, moving a low intensity for a long period is really impacting, and this is something that is being applied in the athletes. So if some of you is familiarized with the cycling or endurance athletes, they are taking now 120 grams of carbohydrate per hour in the Tour of France. So at the end of the day, they are taking half a kilo of pure sugar in their blood. And they are training their guts, and there is a methodology to training the gut to absorb those nutrients better. So this is also, we are applying this strategy in the terms of obesity. That means that somebody eats, and people living with obesity start training just after eating, low intensity, long time, and we are observing that the gut absorption of carbohydrates and other metabolites is improving dramatically. So I think that implementing these strategies, and there is a lot of way of creativeness and innovative things that we can do, can really impact people's health in that way. So I would not focus on increasing the abundance of anaerobic or aerobic bacteria, just focusing on improving gut health.
Thank you.
There's a clarifying question in the app, and that's for you, Joshi. Which methotrexate was studied, parental or oral? Which one is more influenced by microbiome?
Yeah, it's a good question, and that's a question we get most of the time. It's oral methotrexate that and it makes sense. Now, it makes sense, first of all, because that's how we mostly use methotrexate in the US, believe it or not. We don't do that much IM methotrexate, number one. Number two, methotrexate does have enterohepatic circulation, which means that even when you absorb it, it goes back to the gut and gets back into the body. So what applies to oral methotrexate may apply to parenteral methotrexate, although we haven't done the work.
Thank you.
Okay, we have a question from the audience.
Hello, my name is Franziska Weil and I'm from Germany. First of all, thank you for that great talk. And I have a question because lately we've been talking a lot of GLP-1 agents and the inflammatory effects or the anti-inflammatory effects, and especially in rheumatic and psoriatic diseases where inflammation bowel disease is also a topic. Do you have a stand on that? Could you comment on that, where there are the connections, or maybe if there are studies that have focused on that?
I can. A big important study for this meeting is Together PSA. As you
4 minutes.
know, it's a hard question to discern. Okay. The idea that GLP-1s have anti-inflammatory properties on themselves, it's challenging. The reason being, Borja touched upon this, is that losing weight is anti-inflammatory in itself. And so trying to, find out which came first will be very challenging. I'm not so sure. I think there are proponents of the idea that now, all of a sudden, because inflammation got better, that's because of the GLP-1 itself. I have my biological doubts. I think there's no connection that I can think of that directly connects the GLP-1 receptor antagonist to anti-inflammatory effects. But Borja may have a different take.
Well, GLP-1s, as everybody knows, has impacted our daily life for everybody. It's going to change the way that we treat patients, now in the field of obesity and mainly in other many different fields. There are some studies that we are in the ASO working on kind of guidelines, and we have seen, for instance, that there are phase 3 clinical studies that demonstrate that GLP-1 agonists are reducing NFLD, non-alcoholic fatty liver disease, independently of the weight loss. So the biological mechanism of GLP-1 is not super clear for us. We believe that it's going to be targeting some parts of the brain because you have GLP-1 receptors, but it seems that some macrophages, they already have also GLP-1 receptors. So also there might be a relation between GLP-1 agonists with these macrophages, and therefore that might be reducing inflammation. But as Jose said, it's really important to understand whether those effects are independent of body weight loss. And for that, those studies that they are postulating that is reducing NFLD, independently of weight loss, is pointing out that it might be a relationship. But I think we need further biological evidence that really supports the exact mechanisms to really make those points. But we have a drug that we don't really know how does it work. It's good and bad at the same time, I would say. But this is something for the future.
Thank you so much. It's a very promising field.
Thank you. We have another question from the app, and it's addressed to the full panel. If the gut is a friend, how should we view the use of NSAIDs in axial SPA? Is the better understanding of the gut microbiota another reason to avoid or sooner progress to alternative medications? What do you think?
It is a known fact that NSAIDs affect the composition of the microbiome. I wouldn't dare to say for better or worse. Avoiding NSAIDs in SPA is a challenging proposition because I would argue that the majority of people are on NSAIDs at least at the beginning. And NSAIDs have shown good, if not fairly similar, I wouldn't say the same, as more advanced targeted therapies. So I would not go as far as to say because of the NSAID connection with microbiota alterations, we should avoid NSAIDs. I think that those are the aspects of microbiome research that we should be very careful about. I think both Chris and Borja were mentioning that. Because it's true, you shouldn't act upon, if that makes sense. I think NSAIDs have been very remarkable. They have side effects, as you know, but I wouldn't avoid the use of NSAIDs because of that data.
I completely agree with that. I think ultimately the first line in spondyloarthritis is generally HPR input and NSAIDs, and so I think we need to be really careful about advertising that. It was interesting, I think, in your talk as well, being conscious about the impact it has on the fecal calprotectin, and so that if you're looking at and analysing that, being conscious of that in those patients, but otherwise I'd caution.
Yeah, I am not clinician, so I cannot recommend anything on that. But I can say that I read when in the plane came in here a Nature Medicine paper that was published in this February, where they were studying the impact of antibiotics, and they were studying the impact of 8 different types of antibiotics, and they found that there are 3 that even though you take the oral antibiotic 8 years ago, it already has an impact in the gut microbiome composition. So when you go to antibiotics and you see this manuscript, you see that maybe you need to choose one antibiotic on the other depending on what are the output that you want to get into the gut microbiome. So I don't know if those type of studies has been done with NSAID, but maybe also it can be interesting to understanding the impact of these different drugs of subtypes that may have in the gut microbiome. And maybe this can be further developing into the personalized medicine, that maybe this is the way that we should move forward.
Thank you very much. I guess you still have lots of questions, as I do, but we have to wrap up this session. So I would like to thank all the 3 speakers for the valuable contribution and all of you for your attention and engagement. We have understood that microbiome field is evolving and advancing. The key message, I think, that is microbiome science is not confined in the labs. It is indeed increasingly relevant across the rheumatology practice, so our practice for our patients. Thus, we should remain both open and critical, attentive to new opportunities, but anchored to robust science, so robust evidence. We should continue to study this and increase communication with our colleagues. Thank you again for joining this session and enjoy the rest of the Congress.